Okay, I think we'll get started. Welcome everyone. Good morning and well done for choosing Breakout Room 3, where you'll find the most interesting mental health topics and even more engaging speakers. This is Insights from Clinical Practice. Before we get going, can you make sure you turn off your camera and your mic and select speaker view. If you have any questions, you can pop them into the chat function on your right and direct them to the speaker of interest. Michael will facilitate a question and answer session at the very end. So we have 4 speakers. Our first speaker is Dr. Emma Hickey, Jigsaw clinician in Limerick and clinical psychologist. And Emma's topic is a suggested guide on how clinicians might use the power threat meaning framework collaboratively with young people. Over to you, Emma.
Okay, thanks, Jamie. So yeah, I'm going to talk through how the power threat meaning framework might be used therapeutically and collaboratively with young people during a brief intervention. I suppose a quick definition of the framework, it emphasizes that experiences and expressions of emotional distress are understandable responses to difficult circumstances. It highlights that experiences of distress are inseparable from our material, social, socioeconomic, and cultural contexts. So the framework talks about the role of various kinds of power in people's lives, how the misuse of power can pose threats to us, and the way we have learned to respond to these threats. So in traditional mental health practice, these threat responses are sometimes called symptoms. The framework also looks at how we make sense of these difficult experiences and how messages from wider society can increase our feelings of shame, self-blame, isolation, fear and guilt around our emotional experiences. So the main way in which we try to explore the concept of power is by asking a young person what has happened in your life that has been unfair. It's also important to ask what may not have happened in a young person's life and to explore how the absence of something, someone, qualities or experiences may be impacting them. So if a young person might be stuck on what external messages or factors might be contributing to their feelings of distress, talking about their role or position in important areas of their lives and how different types of power play out across these areas might help with understanding what is affecting them. Emphasizing that it is more than who is in these different areas is important. It is about how people come together and relate to each other within each area that can impact us positively or negatively. So these are examples of some worksheets that can help with conversations and dialogue about one particular type of power talked about in the framework called ideological power. It's not a term that we'd necessarily use with young people in session, but what we would talk about is certain language, narratives and messages that are used to support particular societal interests or agendas and how these create beliefs or stereotypes maybe about particular groups. It's one of the more hidden forms of power and operates across areas such as media, advertising and education. Exploring the concept can also highlight why people who do not have an obvious history of trauma or adversity still struggle to find a sense of self-worth, meaning and identity sometimes. So this is a case example of using the framework with a young person. So the first question, what's happened to you or what's happened in your life that has been unfair? This young person talked about being bullied and not understanding why peers decided to do this. That's an example of interpersonal power playing out negatively in a young person's life. They also talked about an older brother calling them names and being angry or aggressive sometimes. And that's an example of coercive power playing out in the young person's life. With the second question, how has it affected you? We're looking at what kinds of threats did that pose to the young person? This young person talked about feeling disrespected, sad, annoyed. It affected their sleep, their confidence, anxiety, and mood levels. At this point, what we tend to do is talk through question 1 again and its connection with the impact on the young person's well-being to help with clarity and understanding. With the third question, what sense did you make of it? We're really trying to focus in on the meaning the young person has developed from these experiences. So what did you learn about yourself, other people, the world as a result? So this this young person talked about maybe feeling like they couldn't trust people sometimes anymore and feeling safer on their own and being by themselves. So our next question then is, what did you have to do to survive? So how did you cope? What threat responses developed as a result of these experiences? For this young person, it was about withdrawing, feeling low, standing up for themselves sometimes, and avoiding social situations. We look at
one minute left. Thanks.
Cool, thanks, Jamie. So we look at maybe the function of the threat responses as well, or the function of the coping mechanism. So for this young person in the moment, it helped them kind of gain a feeling of staying in control and a sense of feeling protected from danger. The question, what are your strengths? This is kind of given the young person the opportunity to reflect on what they've done so far to get through challenges, and the protective factors that might exist in their lives. Some young people don't like that question, so maybe asking like, what do you like about yourself? What do other people like about you? This young person named feeling like they're a caring person, someone who doesn't give up, someone who will keep going, someone who's a good listener. It's important then to integrate these 5 questions. We ask a young person to put their story together to help with clarifying and understanding the connections between each step within the framework. So that was kind of a whistle-stop tour of the framework and how it might be used with young people therapeutically and collaboratively. So thanks for listening.
Thanks, Emma. Very interesting and great to see the PTMF on the table and a live example of conceptualizing distress with threat responses. Next up, we have Dr. Gillian O'Brien, clinical director and clinical psychologist, and Gillian's topic is a longitudinal observational study of supervisory dyads in Jigsaw. Over to you, Gillian.
Thanks, Jamie. Good morning, everyone. Really pleased to have an opportunity to talk you through some of the results of a study that we conducted around our clinical supervision practice. In my role, that's of particular importance to me in terms of my responsibility around the oversight of high quality, safe practice across our 14 community-based Jigsaw services and our online service. And as we all know, clinical supervision is really a cornerstone of good clinical governance. So I'm really proud that as an organisation, we have invested so much time in trying to strengthen and deepen our clinical supervisory practice. And we have done that in partnership with Aisling McMahon and her team in DCU. So I really want to acknowledge Aisling, that was the principal investigator on this particular study. For about 5 or 6 years now, ourselves and Aisling have been working closely together across a number of different modalities, as I said, to try to deepen and strengthen our clinical supervisory practice. So that's been a very important partnership for us. So I just want to thank Aisling and her team, to Kieran, Christina, Sarah, Rachel and Shannon. And also a special word of thanks to the very brave supervisees and supervisors in Jigsaw who participated in the study. And thanks to them and Aisling's team, we have an absolute wealth of information to draw on and to inform our practice. So in terms of the method, there were 5 dyads, supervisor dyads, who participated in the study. They were drawn from our pool of about 110 mental health professionals who work in our transdisciplinary teams. In this study, they were a mix of clinical and counselling psychologists, social workers and occupational therapists. They had a big range of experience. The supervisees had been working in mental health for between 1 to 7 years. The supervisors had been working in mental health for between 7 and 18 years. And all of the supervisors had engaged in a minimum of 6 days of dedicated clinical supervision training and others in much more extensive training. So each of the pairs audio recorded their supervision meetings over a period of 6 months, and they also separately journaled about what they perceived to be helpful or hindering experiences. There's some details there of the analysis that Aisling and her team used in terms of understanding the transcripts and how they coded them. So the supervisory practice contained within the transcripts was explored in real detail by applying a variety of different lenses. Some of them are may be very well known to some of you tuned in this morning. So Hawkins and Showit's 7-eyed model of supervision. We also use Derek Milne's SAGE, so the Supervision Guidance and Adherence Evaluation approach, and Heron's 6-category intervention framework. It was quite a challenge to try to identify which of the many conclusions and findings this study has yielded, but I've tried to pull out some of them that are particularly of interest in terms of our practice. Really important just to say at the start, and that one of the key findings was that amongst the 5 study dyads, there was evidence of very strong supervisory relationships. The supervisees reported supervision to be a really helpful space, and although they were mostly early career practitioners, they were confident clinicians with positive client outcomes. And we know that from analysis of the pre and post core scores. So in Jigsaw, all young people fill out a YP or a core 10 at session 1 and their final session. So that was incorporated into this study. The supervisors regularly shared very validating, supportive feedback. And this was certainly appreciated by the supervisees. But one of the findings and recommendations is that more specific developmental feedback would be needed. So the validation is incredibly important, but in order to help people to stretch and to grow and to learn, and that developmental piece is really important. Supervision, supervisor direction and guidance was also frequently observed in the transcripts, which supervisees found very valuable. There was a lot of focus on case management and kind of intervention-focused conversations. But again, one of the findings is that more facilitative interventions would be recommended to encourage kind of stronger reflective learning among supervisees and really encouraging greater self-direction. So moving from that master-apprentice model to a more reflective experiential model of supervision.
Sorry, Gillian, 1 minute left, thanks.
Sure. The transcripts also identified that there was limited amount of experiential or embodied work, so it's recommended that we consider incorporating role plays, review of live and recorded practice and looking at client outcomes. Theory practice links were seldomly explicitly referred to in the transcript. So while they may be there and people may be holding that knowledge, it's really important to surface it and make it explicit. And then finally, greater exploration of the client-supervisee relationships and processing of the supervisee's emotional reactions would be a recommendation arising as well. So there was a strong focus on content of the work with young people, but less so on the process, the relational components. So as an organisation, how do we take this incredibly rich data and feed it into our practice? Well, we've already very widely communicated the study findings. There's a very lengthy report. We held a workshop for all of our clinical staff in April. We may do one again. Creating reflective spaces to support the integration of findings into practice. So individual, group supervision, reflective practice. We have a discipline-specific supervision. So there's lots of places where we really want to actively consider these findings together. We're aligning them with some other activities we engage in around clinical governance, such as case note audits. We're incorporating specifically the learnings into our CPD and looking at how we can incorporate these learnings into our induction program for new clinicians. If anyone's interested in learning more about the study, because I've really given you a tiny snapshot this morning, I'd encourage you to reach out to Ashley McMahon in DCU. If you want to find out a bit more from the applied aspect, feel free to get in touch with me. And we have a couple of papers currently under review and a few more on the way. So thank you very much, everyone, for listening.
Thanks, Gillian. Very important piece of research and great to see areas for development, be it experiential or process driven. Next up, we have Neil Dhonnagain, and Neil is a PhD candidate in the UCD School of Psychology, and his topic is the Jigsaw Journey, understanding experiences of young people engaging with brief intervention support. Over to you, Neil.
Thanks very much, Jamie. Hi everyone, my name's Neil Dhonnagain, and my project in UCD focuses on brief intervention support provided by Jigsaw. Today's study is focusing on understanding the experiences of young people who have engaged with the service. Now, what we wanted to understand was the elements of the help-seeking journey for young people, and that relates to the things that young people may have found helpful or unhelpful during their time with Jigsaw, as well as the value that they derived from the intervention that they were engaging in. This type of research that looks at experiences is common in psychotherapy research, but it actually hasn't been done that much in in a primary care youth mental health service. So our study tried to bridge that gap. Now, the methods that we employed in this study were qualitative. So we put together an interview schedule, which had a significant level of input from young people on the Youth Research Council, Jigsaw. They looked through some of the questions to see if they were understandable and age appropriate. And we made significant changes to the questions after their feedback. We then conducted the interviews over Zoom. The participants who engaged in the study were 11 young people and 9 members of clinical staff in Jigsaw. But the analyses today are emerging findings that are based on 4 of those interviews with young people, and the profiles there are on screen. All of the names are their pseudonyms of the young people. We used interpretative phenomenological analysis to look into those lived experiences that young people had of engaging with the service. I'm going to focus on 2 themes that we've identified so far in the analyses. The first one focuses on the realities of the therapeutic space for young people in Jigsaw. Now, the young people who took part in these interviews, they had different modes of intervention. So they had phone interventions, they had ones that were in person, and then interventions that all took place online. But a common thread that came through across each of those, regardless of the mode of intervention, was that the role of the clinician was extremely important in providing a warm space for the young people where they felt that they would not be judged for saying anything. So it was an unconditional space where they could say anything that was on their mind. And the reality of this space was actually quite different to the expectations that they had. So some young people had expectations based on, what other people had said about therapeutic experiences, but in the reality, it was quite different. And I have a quote from Kevin that sums this up, but it's something that maybe in the mental health promotion space could be considered, that young people's understanding of therapeutic spaces often can be quite different to what actually goes on. So what Kevin said was, I didn't think there was anything like Jigsaw. I thought for someone who wants a therapy session, they have to pay so much money and they have to go see this man in a chair in his house and lie down on the couch. I had the completely wrong idea of it. You also don't have to worry about it being really awkward or really scary, because it is just like sitting down and talking to someone. That's all you have to do. Now, the second theme I'd like to focus on relates to stories of development. Oftentimes in mental health research, we hear about stories of recovery or stories of healing. And while there was some of that in evident in young people's transcripts, stories of development were the things that really stood out, or it was one of the things that really stood out. So the young people who went through these interventions learned life skills that they would keep with them. These included things like learning to reflect on, the difficulties that they were going through, meditating, learning to observe their feelings, becoming more aware of what they were feeling, and then becoming more open as well.
Sorry, Neil, 1 minute left, thanks.
Thanks, Jamie. And then the other area in which we saw development was in their context outside of the intervention. So a young person had said that a lot of the distress that he was facing came up in school, but because he was able to work on that distress in the intervention, it meant that the school environment actually became a lot more relaxed for him, because he was able to get through the day in school without feeling as anxious as he used to. And the final part that I'd like to focus on is an example from Quiva, where she talked about her family role as being the eldest sister. And she saw this as a role where, originally she saw it as a role where she had to project strength and to be stoic to some degree. But she was talking about the changing relationship she had with her younger brother in setting an example for him. And saying, I'm even teaching him now after my engagement with Jigsaw. Because he goes, I don't need to cry because I'm a boy. And I said, no, you do need to cry, but it's okay to cry. So we could see from this quote that there was a sense of developing, a sense of growing and maturing, and then in being able to set an example for other people too. Finally, I'd just like to say thanks a million to everybody who took part in the study, all the young people, all the members of clinical staff, and all the people in Jigsaw who facilitated the study and supervisors as well. Thanks a million.
Thanks, Neil, and thanks for really bringing to life what we do in Jigsaw with those examples. And it's great to see and hear back on how people are benefiting from the service. Next up, we have Nicola Glynn. Nicola is a senior clinician in Jigsaw Offaly and mental health nurse. And Nicola's topic is exploring the experience of working within a transdisciplinary team, a study of allied health professionals working in Jigsaw. Over to you, Nicola.
Hi Jamie, thank you. Hi everybody. So I'm Nicola Glynn. I'm one of the senior clinicians in Jigsaw Laois Offaly, and I will be presenting a study on transdisciplinary team working in Jigsaw. Before I get into the findings, I just want to maybe talk about what does transdisciplinary working look like in Jigsaw for those who may not be familiar with it. So Jigsaw clinical team members are drawn from a range of disciplines, including social work, occupational therapy, clinical counselling, educational psychology, mental health nursing, and psychotherapy. So in Jigsaw, clinical roles are generic with shared job titles rather than a specialised line with disciplinary training. This reflects the fact that in practice, all members of the team possess core mental health assessment and intervention skills for working with young people with mild to moderate difficulties. Each member of the team draws on their unique experience and training whilst working in a brief therapeutic model. And there is a strong emphasis on shared competencies and cross-disciplinary learning. So with this in mind, the objective of the paper was to better understand the experience of working in a transdisciplinary model in youth mental health. The research was commenced in 2018, and each discipline had a clinical representative as part of the research group, as outlined below. The reason this research took place was that there was a noted gap in the literature when it came to transdisciplinary working in mental health, and also that it was a relatively new way of working within the Irish context. Three key areas of exploration included the benefits of transdisciplinary working, the challenges associated with it, and any additional supports to assist with working in a transdisciplinary model. The hope was that the findings will inform induction of clinical staff and CPD going forward. The design and methodology was that involved clinicians from all levels across the Jigsaw organisation were invited to participate in the research. So this ranged from regional clinical managers through to Jigsaw clinicians working in the individual hub. This allowed us to create a vast experience and range of qualifications across the board. The data collection was completed through anonymous online surveys, with the research questions being both qualitative and quantitative in nature. Quantitative allowed us to collect the statistical data that was needed to show the representation of each discipline, and also the qualitative allowed us to understand the experience on a personal level of clinicians working in a transdisciplinary model. The thematic analysis used was Brown and Clark, and this was used to code the data. From this, 3 key themes with 9 sub-themes were identified and categorized. Under the benefits of transdisciplinary working, the overarching theme was enhanced learning. Staff felt that there was a real element of adaptability, collaboration, and respect that was gained through working in a transdisciplinary model. Challenges, the overarching key theme was the perpetuating prominence of medical model within Ireland. Sub-themes under this was hierarchy, or even indeed the perceived hierarchy coming into a transdisciplinary way of working, the perception of clinical work in Jigsaw itself, and how transdisciplinary working is relatively new in Ireland. Clinicians felt that these were some of the challenges they faced when coming into a clinical role within Jigsaw. Under additional supports needed to assist in working in a transdisciplinary model, the overarching theme was organisational transparency. So staff really felt that professional identity was something they were concerned about, how it would be maintained and recognised within Jigsaw under a transdisciplinary model, and also how the procedures for working within a transdisciplinary model, as it was relatively new to some of those who had started in Jigsaw. Some points for discussion could include statistics of disciplines who participated. So 57 clinicians were invited to participate in the study, with 27 completing the study itself. What do the results mean for transdisciplinary working in Jigsaw? What contributions will the results make to transdisciplinary working in Jigsaw and indeed Ireland? What may require further investigation in the future? And how will the findings be incorporated into Jigsaw's working model, with this already being found as it has been implemented in the induction for clinical staff coming into Jigsaw to help them better understand the transdisciplinary way of working. That is my presentation. Thank you so much for listening.
Thanks, Nicola. You've come in under time, so we've more time for questions and answers. And great to see the research being done on a relatively novel approach to mental health teams and transdisciplinary working. Over to you, Michael.
Brilliant. So I'd just like to say thanks again for the speakers for providing us with their research and their insights. And if anybody thinks of any questions, you can just pop them into the chat box. So I'll start off with a question for Neil. What direction does future research with young people need to go in order to further our understanding of their experience of brief intervention?
Yeah, I guess one of the ways, or at least based on the findings that we've had so far, one of the things that I'd really like to see as a future direction for research is to look at what young people's expectations are when they come into services. I know there was some research in Headspace that had done this, but in a way, I think we could do an awful lot more to help people understand what exactly is involved when someone comes to an intervention, because young people's understandings of it can be conditioned by the traditional idea of therapy and how people understand it. Whereas actually the space that is offered to them is non-judgmental. It's non-directive in that a clinician can oftentimes guide a young person, but they don't tell them what to do or tell them what to think. And they learn a lot of skills from this. But young people's understanding of the therapeutic space, unless they've gone through it themselves, oftentimes is quite different. So that's a future area of research that I'd like to see in order to, I suppose, improve their, like, it could help to improve young people's reluctance to seek help, for example. So that's just one area for future research.
Okay, cool. So how is portrayed maybe by the media and by previous people's experiences influencing it?
Yeah, but even in terms of mental health promotion by services, it could probably focus a bit more on that piece.
Okay, brilliant. Thank you very much, Neil. And there's a question here for Emma as well. What are some of the challenges for clinicians using the PTMF?
Yeah, I was just having a think there. I came up with my top three. One of them is flexibly applying the PTMF with young people. I think that's something I'm still trying to figure out as a clinician. So trying to fit the framework around where the young person is at, rather than trying to fit the young person into the framework. And I think worksheets work well with some young people. I think they don't work well with other people. And I think it might be about using part of the framework, not all of the framework. So really about using your clinical judgment and assessing where the young person is at, and figuring out with the young person, is there a part of this framework that might work well in our intervention? Another challenge, I think, is if a young person is understanding their distress through a medical lens or a diagnostically led lens even, it's maybe not my job or a clinician's job to try and change that, but it's about supporting the young person to figure out that they have options. And one of the options is understanding distress in a different way. But if they really want to explore their distress through a medical lens, it's about supporting them to access the services that might help them do that. And then the last challenge that I've noticed in my practice is maybe sharing the PTMF formulation with families, and getting a systemic understanding of the young person's distress can be challenging within a brief intervention, and probably something I'm still trying to figure out and work on. Okay.
Brilliant. Thank you very much, Emma. And I have a question for Nicola as well. Just with transdisciplinary teams, what are some of the challenges that face, entering into a transdisciplinary team? You're just on mute there, Nicola, I can't hear you.
Apologies. So yeah, what some of the challenges people found was, again, that transparency, not fully understanding what the model looks like, how they themselves fit into the model itself. And, what I suppose the fear really was like, am I skilled enough to work in this way of this model? And also some of the other challenges some people faced, again, like I said, was that perceived hierarchy, that they were coming from an area that may have had that structure, and it was that worry and fear and challenge of, okay, well, how is it going to work in this organization? What does it look like? How do I report things and other things like that? Another challenge some people faced was that comparison, their skill set versus another discipline's skill set, and kind of how do they navigate that area then as well. As some people felt that they had come in and began to feel that they were possibly underskilled. However, that was not the case then once it was more explored, and they also used that supervision outlet to really kind of build their confidence around that too as well, that every discipline, as mentioned in the presentation, have the core skills to work in this area. And some of the benefits of that transdisciplinary work then is that you learn so much from other disciplines without kind of hindering your own discipline, whatever you've come from.
So I think we just have time for one question. So this question is for Gillian. And what, in your view, is the most important learning from the supervisory dyad study in supporting the quality of clinical supervision?
Thanks, Michael. That's a difficult one. I think one of the most important things that I've taken away from it is the finding that there was little emphasis on exploring the process factors, if you like, the therapeutic relationship and the alliance between the client and the supervisee. And that makes me think about how we can support our teams to feel more confidence in leaning into those kind of relational and therapeutic alliance factors and bring those into supervision to really explore what's going on in that therapeutic relationship between them and the young person, and to use that to influence and impact on their work with that young person. So I guess in essence what I'm saying is not just a consideration of the content, but also the process of therapy. The content is sometimes the easier place to go, and the process can feel a bit scary, a bit more nebulous. But I think this study has really shown us that that's where we need to go, and we need to scaffold people so that they feel comfortable and confident exploring that space. Hope that makes sense.
Yeah, brilliant. Thanks, Gillian. And there was just one more question for Emma as well. You know, the PTMF is a fairly new framework, and I was just wondering, how are the service users finding it?
Yeah, I think overall my learnings have been so far that young people have found it a relief to understand their problems maybe more contextually. I think the challenges that I've had maybe with using the framework would be sharing it with family members and getting an understanding systemically of the young person's distress. Also that maybe worksheets aren't for everyone, but I think the framework can still be discussed therapeutically just through talking. So a flexibility in how you use the framework in the room as well with the young person is important. I think at a very basic level, you know, every young person can maybe connect with an unfair experience that they've gone through or that they've had and how it's impacted their experience. So using it at different levels with different young people, depending on where they're at, is really important.
So I think we'll have to wrap up the Q&A session and the breakout session here. So once again, I'd just like to thank Gillian, Emma, Neil and Nicola for presenting today, and also Jamie for co-hosting here today, and all of the attendees also for joining in the talks as well. And I would just like to instruct everybody to rejoin the main screen where the discussions will continue today.
Thanks, folks.
Thank you.